Okay, I just hit record.
Hi, I'm Dr. Jerry Hesch, a physical therapist at Hesch Institute in Aurora, Colorado. And this is a very interesting case. Janine came to see me from Atlanta, and she has had some sacroiliac discomfort on the right side. And what I found when I did spring testing on the pelvis is that on the left side, on the left ilium, I can take up the slack. So I'm pushing with about 15 pounds of force, and all these structures move, the pelvis moves, and it takes up the slack. And now it requires an additional 15 pounds of force to induce movement. So now I do a thrust, and you can see it goes forward and it bounces back, just like when you test a shock absorber on a car. So this is called spring recoil, spring recoil. And when I do it on the right side, I take up the slack, but it keeps going. It goes further before the slack is taken up. And that's an indication of hypermobility, okay? And now I'm going to do the spring, and I spring it, but there's no recoil. Do you see that? There's no bounce back, okay? So that's very interesting. Now, in terms of symmetry, you present with a pretty symmetrical pelvis in the front, okay? Let's have you lie on your stomach. And when she's on her stomach, she presents fairly symmetrical, except the right PSIS is a little inferior. And I don't think the camera angle will capture that, but my right thumb is lower. On the top of the shelf here, it's subtle, but this iliac shelf is also inferior. And then if I come underneath the ischial tuberosities, it's simply too subtle for me to tell. It's a little bit obscured by the gluteals. The sacrotuberous ligament is an oblique ligament, and on her left side, I can indent that ligament a little bit, and I can spring it, and that's normal. Okay, it's a very powerful, very strong ligament, but it has a little bit of yield. Okay, on the right side, I cannot indent it. It's really tight. Okay, so I cannot spring that ligament, and in fact, that ligament is more posterior towards the ceiling. Okay, now I'm going to do a superior spring test, and I can see your head bob up and down, so the force goes through the sacroiliac, through the lumbar spine, all the way up her body. Okay, and that's normal. When we come to the right side, I cannot even take up the slack, and I'm using a reasonable amount of force, 15 pounds, very similar to the force on the left, and there's no give. Now I'm going to double that force, and there's no give. And I'm now going to do an inferior spring, and you can see her feet bob up and down. So the force translates through the sacroiliac down into the hip joint, all the way down to her feet when I do an inferior spring. Now here's what's interesting, is that on the left side, she's stuck. I cannot spring this inferiorly. And the mechanical diagnosis of this is a downslip pattern. And the theory is that the ilium has slid down on the sacrum and become stuck. Now, typically when you have a downslip presentation, you lack superior mobility. I mean, that is how it presents. And you have a tighter sacrotuberous ligament. But typically you can actually make it go a little further inferiorly when you do the spring test from the top. But for whatever reason, her anatomy is unique such that with her downslip pattern, she does not have inferior spring mobility. Lots of controversy on the sacroiliac joint, lots of controversy on how much movement is there. And I submit that we don't fully understand this system. But you'll note that I have several YouTube videos on the topic of downslip ilium, and perhaps it partly involves the sacroiliac joint, and maybe it involves muscle phenomenon. The nervous system certainly is involved. It's, you know, one can debate for it and one can debate against it, but what I'm all about is a practical solution. I'm interested in normalizing movement because this movement is normal physiological movement on the left, which is absent on the right. She does have pain in the region of her right SI joint, and that hypermobility is really rare. That's quite a rare finding in a person. There's a lot of people who believe they have hypermobile SI joints, but this is a true case of what I'm going to call a positional hypermobility, and I'm stepping out on the limb a little bit. I'm suggesting that when I mobilize that ilium superiorly, that then I will restore stability and restore mobility. So what I'm going to do is I'm going to mobilize this hemipelvis, applying a superior force, and I'm going to apply that times 5 minutes, okay? Then we'll come back and we'll refilm the spring testing and the palpation of the ligaments, and we'll also discern how you feel subjectively. Now, the average angle of the sacroiliac joint in the frontal plane is basically a 20 to 30 degree angle, okay? So if I want to move her right ilium superiorly, then I want to find that angle that allows superior mobility. So let's have you lay on your back. And I want you to scoot down so your feet are about 4 inches off the table. And you'll notice that on the left side, I can create vertical force. I see her head bob up and down when I push up through the foot, okay? On this side, she's stuck. She's stuck in a pattern called Downslip Ilium, and I cannot induce superior mobility, okay? What I need to do is try to estimate the angle of her joint and find that sweet angle that allows vertical force to occur. So if I adduct her about 15 degrees, which is typical, now you can see her head bob up and down when I push through her foot. So this is the treatment angle. And I must say that throughout her day, and she's very active, she's a personal trainer, throughout her day she does not get her hip in this direction. Am I correct?
I guess so.
Okay. Let me also state that there's osteopathic theory that states that downslips are common, but they self-correct through walking, and I have to say that's simply not true because you've been walking a lot. You're very active. Mm-hmm. And you have not self-corrected this pattern. No. And it would require that you stand and weight bear with your hip in adduction, and that you do that for a prolonged period of time to self-reduce. There's a couple of other ways to self-treat it, and I'll teach you those. But what I'm going to do now is I'm going to just capture that sweet angle, and I'm going to push and load the joint, and I'm going to keep that force steady for 5 minutes. And then we'll come back and refilm, and I'll also show you the self-treatment on the film as well. And again, there's a lot of controversy on the SI joint, and is this really an SI pattern? Is it not? Is it more of the nervous system? And again, I'm going to suggest that a normal pelvis has normal mobility and normal stability with these movement and stress tests, these spring tests. And my goal is to restore normative function, and that's my goal. Thanks very much.